All right, next we're going to transition, take a couple minutes to transition into a panel discussion on how to mobilize, innovate, and thrive. So I'll go ahead and ask the moderator and panelists to come up. Okay, and this is exciting. Tom mentioned in his introductory remarks about our presence at the mHealth Summit this past December. And as you said, a roundtable discussion on the last day of the conference. It's attended by more than 60 people. It was pretty cool, and I think really what our goal with that was really to take what we've been doing at the Knowledge Network Summits and move it into a wider dialogue with the hundreds, really thousands across the country, but at the mHealth Summit, these entrepreneurial companies that are moving into this space, marketing to consumers, marketing to providers. It's really exciting to see all the technologies out there and the way we can use mobile to really enhance care, make it more personal for the patient, make it more profitable for the provider, really solve this value equation. And so we wanted to have a panel discussion today following up from our conversation at mHealth Summit. We actually have a couple folks from the mHealth Summit here. I think Ed Connors from Media Health, Mike Byer, we've already heard from M3. And really this is about, we know you all as providers are really trying to sort this out, like what do we use, what tools are out there, what's best practice, it's hard to make those decisions. And so really this is a conversation where you can hear from three leaders in this space and start to have some of that discussion. Also, so I guess I'll just go ahead and start by introducing our moderators. This is Wayne Easterwood. He's our CIO at CRI. Prior to coming to CRI, he served for 13 years with Centerstone as Vice President of Information Systems. So a lot of experience on the provider side, and now heads up information technology through the Research Institute, and also has experience with Qualifax Systems as Director of Implementation. At Centerstone has led the infusion of technology and EHR functionality to the desktop of clinical staff, and is continuing this work by overseeing the merger of 4 electronic health records and our ongoing transition to always have our EHR up to date and reflective of bringing research and technology into practice. His expertise lies in advanced design teams, training, go-live support, and software development. And despite all of this that he does for Centerstone, he stays very current in latest mobile tools, whether it be a running app he's telling me about, nutrition, all kinds of really cool stuff. He's on the forefront, always keeping up with that, which I think is really incredible. So he's perfect to moderate our panel today. I'm actually I think we're going to have the panelists introduce themselves, but I'll just briefly say we have Scott Cousino, a CEO from myStrength, which we've heard some about today already. We're excited to have him to share a little bit more about what they do at myStrength. Ashley Boyd, who's Director of Business Development and actually also Ambassador for Rock Health, Women in Health, which actually I'd love for you to share a little bit about that at the end of the panel. She is Director of Business Development at SBR Health. And then we also have Bevey Minor, Business Strategist for Ginger.io. So we'll go ahead and get started. Thank you guys for being here.
Yeah, I'm very excited about this. I'm going to ask each of the panelists to really introduce themselves, a little bit about their organization, and then we'll get started. Bevey, why don't you start?
Okay. Can you all hear me all right? Good. So I'm Bevey Minor. A little bit about myself. I've been in this industry for about 15 years. Started in health information exchanges, moved over to Allscripts for about 6 years, and then most recently been in mobile health. So joined Ginger.io not too long ago, and what we do is essentially turn this into a sensor device to monitor your life and to monitor your behavior. So we look at different nuances of changes of that behavior. How many outbound phone calls did you make? Did you call the same people? Did you call different people? Did you drive the same 5 miles to work and then another 3 miles to get to the gym or socialize? Or have you even left the house? We look at whether you unlocked your phone at 2 in the morning, which indicates sleeplessness. And we run all that through our analytics engine that was developed at MIT by our co-founders. And we do science behind all of that. So we look at a signature that tells us if this, and if this, the patient is likely to be going into a state of poor self-management. So then we can employ some interventions, whether that's an alarm and alert sent to a case manager, a physician, or a caregiver, or even just directly to the patient that they need to call their support network because they're giving us indications of poor self-management. So our objective is to do predictive analytics and to look at ways we can do early intervention.
Thank you. Ashley.
Hi, so I'm Ashley with SBR, and just to give you some background on me and my the reason I'm in healthcare. 10 years ago, I was diagnosed with type 1, which is not something that most people want. As a result, I actually found it to be a really positive and empowering experience. So I'm in healthcare because it's my life. And so I joined a startup 4 years ago, SBR Health, and our focus in the space is really, big picture, looking at ways that we can improve people's health through better communication. So living with a chronic condition, I understand, really some of the challenges, in regards to access, and in learning more, from the clinical context. How do you integrate video communications into workflows? That's been a big problem with video communications. Is it's great, it's exciting, it's really advanced, it's come a long ways, but there's been a struggle in really integrating video specific to healthcare needs. And so that's really what we specialize in, is matching it to healthcare organizations, hospitals, both the clinical and the business objectives for care delivery. Our end goal at the end of the day is really to recreate the healthcare experience so that it does include that virtual care component, and making both patients, helping them better manage their conditions, but also enabling providers to just be more effective in delivering care.
Thank you. Scott?
So I'll start with myStrength first, because I think it's a little more exciting than Scott Cousino, but I'll kind of weave in my background. myStrength is a 4-year-old company. We've developed mobile and web technologies that effectively operate as treatment extenders in the public sector. We're working now with over 30 community health organizations across 13 different states. We've trained about 5,000 community health clinicians, peer specialists, physicians who are using myStrength to really augment direct intervention of care. On the commercial side, we're working with some large players like Aetna and Simpatico, who are also launching us to their primary platforms. The intersection in terms of how I got involved, I actually struggled with depression 15 years ago for 2 years, and really struggled with stigma. And ultimately, I was blessed with financial means and loved ones to help me seek out a therapist, and had a life-changing outcome as a result of that. Fast forward, I was running an organization that just happened to be an online learning company. I had 600 employees, and we were doing review of healthcare costs. And as we were looking at the costs emanating out of behavioral health, we challenged our healthcare provider to come in with tools and technology around depression, stress, and anxiety. And they came in with an online article and a video. And we said, boy, if that's the level of innovation taking place in behavioral health, there's probably an unmet need. So with the blessing of our respective wives, we set off on this incredible journey where we've taken evidence-based content and combined it with Facebook, Pinterest-esque-like applications that really harmonizes, I think, what's critical around consumer engagement with the efficacy of the underlying evidence-based models. And what's been exciting, particularly as we've scaled over the last couple of years, is beginning to see lots of great data that ranges from not just a consumer engagement and satisfaction, but some demonstrated outcomes improvements as well.
I think it's an interesting contrast that many of us in the room are maybe have been in healthcare for a long time, or with organizations that are trying to figure out how to transition to what we can see as a new way of healthcare delivery. And the contrast is each of these organizations are very new. They're part of that transition. And I hope as we talk, we're going to begin to think about how does this impact. Instead of I'm an organization trying to transform, these are the kind of tools that I think will lead us into that transformation. So I'm going to start this off just thinking in the spirit of JFK's vision of taking a man to the moon. CMS has given us this triple aim. So improve care, improve healthcare delivery, and drive the cost down. So in the spirit of that triple aim, and in the context of the clinical environments, how do your products, your organizations, these innovations, how do they bring value to care? Bevey, why don't you start us?
So I've focused on the three-part aim for a long time, considering that at Allscripts, our CEO was very instrumental in working with Obama before ACA was introduced. and understanding how can you measure these three really critical pieces of healthcare and weave them into best practices. So when you take whichever order you want to put them in, but if you look at better health, and that's been a confusing one to a lot of people to explain what's the difference between better health and better health outcomes. Better health is about the transitions of care. Better health is about the satisfaction of the practitioners and the patients in care. It's better integration and case management with patient engagement and care collaboration. And on that area, we think we score pretty high because we have a huge level of patient satisfaction just in our application in the way the patients can be connected to their entire support network, which is either a clinician, physician, or even a caregiver, which would be a daughter that may be able to see that their mom is going into some sort of poor self-management and be able to do an outbound phone call. It could be a parent to a child. So that's under the patient, really the better health. Under better health outcomes, we've heard a lot about what we're trying to do in the industry with better health outcomes, and I think we just have to get better at this, because behavioral health leading to better health outcomes is a real key to show the efficacy of what we can do. But not until we integrate into other care models will we be able to really show better health outcomes. On the cost side, I have been talking to a lot of you at the conference today about where can we see well-managed, well-integrated behavioral health programs equal lower costs, lower admissions, lower ED visits, because we aren't integrated into those cost models. We aren't integrated into taking a look at encounter data along with behavioral health data. We're getting there, and I think it will be better, but we get a lot of pushback on our payer clients to try and say, where is the lower cost? Our ACOs are, I need to see cost. So we're starting in a phase 2 project right now, phase 1 projects with a number of our clients to set that up, specifically to look at where can we measure these outcomes and how can we manage to cost of care. And we just heard that claims data, it's so latent. Even after our phase 1 projects, it'll take 90 days just to get the claims databases updated, and after that, another 60 plus days to have the actuaries start to crunch through that claims data. So I think that's one of the challenges we all have in the industry, and we're still trying to figure out that cost model.
Okay.
So I'll share just a few places where we're demonstrating a lot of success. For us, it really starts number one with access. Big challenge with patients, particularly ones that are dealing with a chronic illness or even a mental health issue. Access to care is a huge barrier. That's one place that we are, helping really dismantle that. Another area with better access and really a tool that integrates into clinical workflows. We're helping improve patients' overall health. They're getting the care that they need. We're delivering it to them wherever they are in place and time. Again, patients are demanding that care be mobile. They're on the go. They want to connect where they are in place and time. So that's another area. And then the last piece, which I think is still very important, is clinical efficiency. If you don't have provider adoption and you're not enabling your providers, the providers that you have, to be more effective in how they're delivering care, we don't see that there really being a future there. But I will be honest and say, the value that we're providing, we're really learning as we go. Some of our customers include Mayo Clinic, Partners Healthcare, who are developing these strategies. I'll share, Mayo Clinic by, I think it's 2020, they have a goal of 200 million visits. They're going virtual. They're setting these goals, taking on more risk. They're looking to take better care, of their high risk, the chronic patients that need their care. And so, I think we're on the right track, and we're certainly really hitting some targets in terms of, the triple aim. And again, we're learning as we go, but it's been an exciting process.
Wow, thanks. Scott?
I think there's some consistencies, and I'll offer some examples as well. I think at its foundation for us, it's really improving the patient or consumer experience. I think Denny and others have really hit on what we consider to be a dramatic shift that will continue in healthcare around consumerism. But at its foundation, it's bringing patient-centered, customized, effective evidence-based tools to the population. Specifically, as we kind of think about the consumer experience, and I'll use the community behavioral health space as an example. As we think about, for example, reaching out to rural consumers, we're working with an organization by the name of myStrength, who operates on the western slope of Colorado. They have a 10-county footprint. Most of those counties are rural. And even if those patients can overcome obstacles of cost and stigma and access, myStrength has only a handful of professionals in some of those counties. And so myStrength is being used as a way not to replace that clinician, but to get technology, to get evidence-based care out to those geographies. As you think about moving kind of closer into the intake process, we are working with Preferred Behavioral Health in New Jersey. It's a relatively new partnership, serving a very sizable footprint, over 300,000 covered lives. And unfortunately, as a result of the covered life population versus their existing capabilities, they have a 30 to 60-day wait list. So myStrength is being used, again, not to replace the clinician, but as an immediate resource to begin to expose these consumers to evidence-based protocols. I think the richness is really kind of as the consumer interacts with the clinician. And so how can we provide technology that can bridge between sessions? And so there's a number of examples. Camus at Healthcare Services using peer specialists. We've got a community counseling in Pennsylvania who's developed a psych rehab group around the technology and the content as a way to deepen. And then I think lastly, the relapse management. So as consumers wind off or step down from therapy, the ability to use technology to really complement that. I think the population health, one kind of interesting side note is that all of our partners have also launched it to their internal staff. And we've seen some of the largest consumers being clinicians who obviously need to cultivate their own health and wellness. But we're also seeing it being used to really tie partnerships together. So we're working with Henry Ford, and they're integrating myStrength into their depression care initiatives as a way to, again, provide PCPs with additional capabilities beyond a referral and pharma medication. I think on the cost front, I think the comments are well stated earlier. It's tough, it's hard, it's complex. We're beginning to understand the impact on the cost equation. We're getting lots of data that's coming in from our systems and capabilities, but I think the opportunity is to partner with providers to really look at utilization of our technology and is there an offset? Is there an offset with utilization? Is there an offset with lower pharmaceutical utilization? And so we've got a number of initiatives in place. We're working with MHCD, who's starting to include myStrength as they prescribe medication through their in-house pharmacy, and we'll begin to look at the interplay between utilization of technology and the pharmaceutical utilization. And then we're partnering with large payers and providers like Simpatico, where we're going to do some historic analysis on utilization in different cohorts of data. But I think this one will take a lot of time. But I think similar to the other panelists, I think we're understanding the cost equation and we're building in the right analytic design to our partnerships such that that data hopefully can be very informative as we scale.
So as I think about this, I get really excited about the possibilities, how things can change, but as we all know, there are barriers. So there are organizational barriers, there are reimbursement barriers, there are consumer barriers, culture barriers. I'm going to open this up to anyone. Talk about the kind of barriers that you guys have encountered in these implementations, and what are some examples of ways to overcome those?
So I think one of the key challenges is clinical integration into clinical workflow. So we all have some really great solutions and tools, but when you ask the physician to take a few minutes out of their time to go log on to a different application, look at a different dashboard, and then get some key metrics and have to go back into their EHR and do double data entry, it is daunting. Also then on the flip side, integration into an EHR, having to be mapped where all the physician activity and data already is hard for both sides to be able to do. There's a bridge called single sign-on and patient context passing, which helps as physicians are trying to go to other dashboards because they don't have to be re-authenticated at that point. And if they're looking at my chart, they see my data and activity in another dashboard. But I believe we have to be able to look at integration into these systems to make that workflow really easy. So that's one of our challenges. And many of our phase 1 projects, we're not doing that clinical interface right now, but we are absolutely being told when we go to broad scale rollout, you need to integrate into Epic, you need to integrate into Allscripts. So we have to figure out ways to be able to do that, whether it's an HIE we just simply integrate into, or if it's that we can map and add our data and value in context to what the other clinical systems are.
I would agree 100%. I would say for us, it starts with the workflow issue. When you look at video, again, video has been used across different industries, with a lot of success. But healthcare is a different challenge in itself, from security. When we look at replicating all of the things that people do in a traditional in-clinic setting, patient comes in, you have to check them in, you room them, you want to notify the doctor, you're routing, you're letting the doctor know there's a patient here. You're getting some data, asking them how was your visit. These are all issues and things that we're having to integrate into the workflow to really make this a positive experience. And then the other, the big elephant in the room is, the payment models. I mean, again, the times are changing. We're straddling the fee for service and looking at accountable care. So we have, a mix of people, who are looking to innovate and get ahead, but really, what people are doing, the payment models aren't quite caught up yet. So you've got some game changers and people who are, making great strides, but not everyone's there yet. So it'll be an interesting next couple of years to see how that evolves.
I think we see 3 levels of challenge. The first is just in terms of the ability to access technology on behalf of the consumer. I think David referenced some great statistics. There's been some wonderful research that's come out of Pew in the last 12 months around digital divide and technology, really looking at the lowest socioeconomic categories and their ability to get onto the internet, their ownership of smartphones. And there's no question the data is very compelling. To include the lowest economic range, 10,000 or less, it's estimated that about 70% of those consumers still have the ability to get online. That being said, and I'll go back to Camus's organization, serving a very poor community, low funding rates, there are certain consumers that just don't have the technology. And so opportunities for pilot and partnerships there consist of, we're thinking about iPod shuffles at $40 and can we load content up, and Camus and I are thinking about foundational work that we can do to kind of fund some of the technology and building out clubhouses within the facilities, as I'm sure many of you have them. So that's kind of the first one. The second one, I would completely agree with the clinician adoption, and here's what we find. And again, back to Denny's presentation. The CEOs, the folks in this room intellectually get it around technology. It's for many, I think it's a sustainable necessity to begin to think about these tools and how they can fit into their model. The clinical directors very much understand that this is a resource that needs to be incorporated. I think the interesting part, and I think this is, Tom, for the knowledge network, the change management process, which has come up frequently today, I think really is an underserved opportunity. Because here's, again, practical examples. When we first started off 3 years ago, and I'm looking at Roy with MHCD, we went in and we had this great bell and whistle technology. And we said, okay, clinicians, we expected, the heavens to open up and these clinicians to, and the clinicians kind of said, well, I just implemented an EHR. I've got 3 practice changes that my clinical directors are trying to instill. I can barely keep up with my caseload. How do I adopt another practice change? And for us, that's been the most transformative part of our business. We continue to innovate on technology, but I think more of our innovation recently has been how do we help the clinicians understand 3 basic questions, and that is it effective? What's the benefit to the consumer? And most importantly, if I'm a clinician, how is this going to benefit me? Now, how is it going to add efficiency to my schedule and help me manage an already overwhelming workload? And so what that translates for us is case planning tools and online tools for the clinicians post-training. And we formed a whole provider network where we build communities of clinicians who are trying to adopt this technology because the learning is just beginning. And I think that is a very rich opportunity, I think, for this space. I think systematizing, and we're talking, with folks at NetSmart, we're very excited about that. I think building it into the workflows are critical. I think even up front, and Danny and I had a conversation 2 years ago about just starting with the academics of training clinicians around technology. I think there's opportunities there. The last bucket is clearly around cost. And this is where I will push back a little bit on Denny's presentation. There's no question that a capitated model affords the ability to use available funds to think about integration of this technology. Of the 13 states, 8 are fee-for-service states that we're working in right now. And I think there's a couple considerations there. One is, our price point. Can we keep it at a level where a thinly capitalized community health organization can bring it in? But the second is we're seeing some really interesting things evolve. State of Michigan funded a number of innovation grants to kick off these tools like myStrength. Foundations, our last 3 partners came on board with foundations who kind of kickstarted the activity. And then lastly, we're about to announce a pilot with a payer and a provider, and the payer is going to start to reimburse for the thoughtful use of technology. And so even if you operate in a fee-for-service state, again, appreciating the reality, we're finding very creative solutions of providers that are finding funds in partnership with myStrength to begin to implement the technology.
So we've got just a few minutes left, so I'm going to edit and mash up the last what I think are about 3 questions, and let you guys kind of pick out what you want. I think we've heard a theme. Each of you are very interested in research and effectiveness, and especially knowing that your products, that your services are working. So really, how do you know? Why are you interested? How do you know? And more importantly, in today's world of innovation, the demand is to iterate. You got to assume there's a huge chunk of what you think is going to work isn't going to work, and you have to change and reinvent it. So maybe pick out any of that you'd like to comment on, that sort of that continuation of that question.
So when we look at innovation, much of our solution is based on science or signatures. So we start out in a research project looking at how we can manage as an example, the diabetic patient with comorbid depression. And we look at aggregate numbers to show different patterns passively that would indicate the patient's going into poor self-management. And then it's validated by either a PHQ-9 survey or some sort of a visit with the clinician to show the patient's going into poor self-management. So what we're constantly trying to do is look at other ways we can deal with, for instance, chronic pain, which is another one of our big research projects, is to look at rheumatoid arthritis, migraine headaches, irritable bowel syndrome, just a lot of the different chronic pain models, and seeing if we can aggregate a population of health in that area and look at the different changes of behavior with patients with the same type of conditions, and then being able to look at predictive analytics before the patient interacts with the system. We're part of UC San Francisco's project with the Framingham Heart Study, and we're starting to see some really great results in terms of if the patient does this, this, and this, can we prevent a heart attack? And look at ways that we can do that early intervention. So for us to continuously reiterate, it's about the science and always making sure that in our machine learning environment that we have more and more patients that are contributing to the smartness of our analytics engine, and we'll get better and better and more fine-tuned of being able to look at these predictive indicators before the patient starts utilizing the system.
Yeah, I would add to that and say, for us, it's essential that we be both agile and flexible in our approach. We've had some success. We started with pilots with several, large healthcare systems a few years ago, and it was a learning process for us. What we learned was that care does need to be patient-centric, but if you look at the healthcare ecosystem, from telemental health, diabetes, chronic disease management, Parkinson's disease, there are different use cases, there are different workflow needs, depending on your patients, depending on your practice. So what we found was we really did have to be flexible, and we had to be able to come to the table and really provide a custom approach that matched the workflow needs, as well as the demands of the patient. If you've got a patient that needs, more frequent interaction with the care team, you're going to need to get, the entire care team on board. We assist with the training, the setup, making it very easy for healthcare systems to, flip a switch, deploy it, trying to minimize kind of what he said in change management, making it easy to support virtual care delivery. So again, we don't really have a one-size-fits-all solution. I think that's what you'll find, with a lot of new companies, is you have to be flexible. You've got to come to the table ready to really partner and provide, hospitals and healthcare systems, folks who are looking to change with something that works for them.
I think one of the advantages of not being from healthcare is you can come in with a slightly critical or constructive view. And our view, as we entered into this space, was that a lot of technology in the healthcare space had historically been developed with a kind of if you build it, they will come mentality. And there's a lot of cautionary tale to that, because there's 10,000 plus medical apps, very few are driving activity. And so I think the opportunity for us coming into the space is to take wonderful academic research and evidence-based practices and think about how we scale those applications into the real world. How do we think about an unmotivated, depressed consumer, and how do they interact with technology, and how do we deal with a clinician who's overwhelmed, and to integrate that into their practices. And I think that's, for us, the essence of innovation, is really understanding how to balance the need for data and efficacy. Mary, I thought your question earlier around the design, I mean, we've had a number of experiences where something looked really good on paper. And we started off asking multiple questions because our providers wanted to get data. Well, the flip side of that is, as we looked at the engagement funnel of our tools, folks were dropping off. When you get into a digital consumer experience, it's an entirely different relationship with the consumer. And so I think our challenge is translating these wonderful evidence-based models that we know fundamentally work through intervention in my case, and really understanding how do we then translate that to the digital world as we think about engagement and effectiveness. The other part to your question, for us, we've got an effectiveness pyramid where we start with engagement and satisfaction. So how many times is the consumer coming back? How much time are they spending on the site? How much downloads are they doing from our mobile apps? We're maniacal about that front level engagement, because we know that's a leading indicator. If we've got evidence-based good stuff in the tools, if they're interacting. But then I think it gets into the clinical efficacy, and we've integrated a number of different assessment tools that we give at various levels, so we can go back to our payers and providers and share the various outcomes trending.
Yeah. How many times have we seen, apps that we look at them and terrific looking, but people aren't using them. I think that's to your point. I'm going to open it up for questions. I hope.
I just wanted very briefly, if I could
take it.
A brief detour from question for just a moment. I really just wanted to stop and take a moment to recognize Linda Rosenberg, who is here joining us this afternoon. Really, thank you. I mean, the National Council has been such a wonderful supporter for all of the work we've done with the Knowledge Network over the years. This is our 10th, and we've been together the whole way. So I just wanted to take a moment to recognize you.
And thank you for your leadership and this fabulous panel. I just left another group going on around I just left. I have a microphone now. I'm so loud, usually I don't need one. But I'm delighted to be here, and I wanted to thank Tom, really. The Knowledge Network was a great idea. I remember when it first started, and your leadership has been really tremendous. I just left another group that's looking at kind of the future of integration, of integrated health, and I actually ended my presentation all about technology, because I think we are just beginning, kind of the early adopters, to realize the potential impact it will have on people not only managing their own health, but really on extending, if not replacing, staff. I think it's happened in other industries. We haven't been thinking about it that way. I don't know if it's good or bad. I don't think it's a value judgment. I think it's just going to happen. I always say, think about bank tellers versus ATMs. You know, it's happened in other places, and it really extends our reach. You know, so I'm thrilled that that's what you're focused on. You have some very important people up there, particularly myStrength. I'm actually going to be talking about someone who uses myStrength in my plenary tomorrow morning. So I'm thrilled to be here again. Thank you all for being here and for being at the conference. We're thrilled. And have a lot of fun.
Thank you, Linda. I hope that there's been some questions boiling in your mind, and you can't wait to ask them. We're going to open it up for some questions for a couple of minutes here.
Thank you for the presentation. A question really to each of the panelists. No doubt there's a great deal of value in the information that'll be collected, both from the standpoint of clinical decision making as well as, you know, potentially program evaluation, et cetera. I'm wondering what each of your organizations is doing to, how do you go about promoting engagement or incenting engagement with the applications? Do you maybe comment on how to bring an adherent patient population or consumer population to use these applications?
I mean, it's a great question, because when you look at, in some areas where the industry is trying to go, it's this notion of prescribing an app. And will physicians really encourage their patients to not only adhere to their medication or their other treatment protocols, but to adhere to technology integration to advance patient engagement? Or even a case manager upon discharge from the hospital sitting with their patients and saying, you know, we want you to have these Bluetooth-enabled devices to manage your CHF, and we have this other application that can help manage your depression. Physicians and case managers and clinicians notoriously don't want to be in the sales business of selling another type of solution. We found that particularly true with a lot of case managers. Physicians and psychiatrists see our application as an ability to have some keen insights into the patient to make that visit a lot more effective. But we as an industry have to be able to show how these solutions and tools will make each one of these clinicians much more productive. And then the other area I think that's quite fascinating is, how do we bring a caregiver into this ecosystem so that we can alleviate some of that demand on clinical staff? And if we get caregivers to figure out how to engage more in their loved one's care, I think we'll end up with an intervention model that will happen from those that you most trust and those that you're actually closest to. So that's some of the areas that we're working on to try and advance engagement.
I would add and say, we really try and start by understanding the problem. Instead of bringing a solution to you, claiming that it works, we really try and sit down at the table and understand, from an organizational standpoint, the healthcare system, what are the challenges that you're facing, but also, secondly, where are you looking to go? I had shared that, Mayo Clinic, they have this goal to reach 200 million patients by 2020. You've got more and more healthcare systems saying, I want to, deliver better care to my patients and really rethink the entire experience. So the only way that we're going to enable them to get there is by working with them to really solve their problems and provide them a solution that matches those problems. It's really a solution that combats what they're facing. providing value to both the healthcare system, the providers, and the patients. So it's a win-win for everyone.
There's 4 things that we're learning for us around consumer engagement. The first is clinician adoption. And so that it all starts there. We go on site, we case planning tools, and it's not about educating them on the technology. It's about, if I'm doing a group session, how can I best use this technology? It's putting it into their practical environment and then giving them lots of resources to keep it really simple. So that's bucket 1. Bucket 2 is in the design of the technology itself. And the best example, as some in this room have heard, when I was struggling with my depression, I was blessed with this therapist who recorded all of her notes. And she gave me the notes. And so I started this folder called Hope in my briefcase. Folder went with me everywhere, but I started to add into the folder biblical quotes, pictures of family, other motivational, inspirational resources. I could only afford to see my therapist once a month, but that folder of hope for me was a lifeline in many ways. And so as we design technology, I think for all of us, but just speaking on behalf of myStrength, we're trying to keep that in mind, that at the end of the day, it has to be simple, it has to be meaningful. And the way that we try to do that is on multiple levels, from myStrength, the health club for your mind, or the gym for your mind. We want to destigmatize that to we've got evidence-based models around CBT and mindfulness, but we also integrate wellness content and spiritual content. If folks say that that's important, we've got that content available to them. The third bucket is around motivation. We're learning a ton about motivation, particularly around mental health. Integrating in simple gas gauges. If you tell me you're overwhelmed, I'm going to give you a different experience than if you're a little bit more motivated. We're going to launch substance abuse in 60 days, and we're integrating motivational interviewing into that. And then lastly is you got to go with multiple modalities. You've got to go web, you've got to go mobile. And so for us, those are the 4 things that as we continue to look at driving that engagement, all 4 have to harmonize for us to really drive, I think, the results that we're looking for.
Yes, my name is Harrison Tyner. I'm with We Counsel Solutions, and I'm actually in telehealth as well. And I just had a specific question relating to piloting in general, some of those processes that you go through. In my experience, the difference between having a successful pilot and one that might flop, due to lack of participation on the provider and consumer side, is having that champion on the other end who's going to really whip the providers into shape, almost kind of force adoption, at least in that time frame, until they get to the point where they can actually, feel comfortable and kind of release them and go on without having to encourage them too much. But that's kind of my experience. I'm wondering, in those pilot settings, are there any other kind of X factors that really help when you're actually structuring it that make the difference between something that's going to be successful at the end of the day, as opposed to something that we really weren't able to gather much data from or get much conclusive results out of?
So I think the whole motivation factor behind getting both the clinicians and the consumer to want to have this level of engagement, in summarizing some of my co-panelists here, it's what are you trying to solve and what are you trying to change? For the patient or the consumer, it's about wanting to feel better, wanting to get better. They really don't, as we heard earlier, need to have the nuances of how all that's done at the back end of workflow. They just want to know that these tools and solutions are clearly going to make a difference. And one area we've seen that is that we are creating a whole new demographic of depressed people when 60% of caregivers for a mom or a dad that are going through memory issues have depression. Clinically depressed patients that are on all sorts of different kinds of therapies to manage their depression. So when you look at just that population, they're very motivated to manage their stress. It's impacting work, it's impacting home life, it can lead to divorces. It's very, very stressful. And I've been a caregiver of an elderly father who had numerous chronic illnesses, and I know personally how bad that is. So how can we manage that population, which is already motivated to want to do something different? And then the rest of it is really up to education. When you can educate the provider of care that we're matching to their goals, of having a visit be more productive, or having engagement outreach and continuous care models instead of episodic, they can see how this can be a total tool for them to have keen insights to their patients. And then when you look at the patient side, it's really trying to match to how can we make you feel better. Patient doesn't want to wake up tomorrow and feel just as bad as they do today. So if it's all driven around managing their condition, I think we have a lot of motivation for that.
You know, I'll add and say there was a presentation on quality measures, you know, really the quality measures for success. And I really like that because, you know, we focus on that. We try and be upfront with every new project, program we take on. You know, here is exactly what we're going to do for you. We want to partner with you to help you, you know, be more successful. And that, you know, goes, you know, really long ways. Especially, you know, we do a lot of work in tracking, you know, patient satisfaction, provider satisfaction. You know, a lot of things that we've incorporated and built into the product so that we can track specific things related to, you know, efficiency, satisfaction, you know, just a lot of different data points that we collect and we make available to the folks that we work with, so they have, you know, some clear evidence right in front of them, and they can say, is this successful or not? And so far, you know, through these pilot programs that we've done, you know, we've been successful in, you know, collecting, demonstrating the data, and that's really attributed to our growth and helping our customers grow their programs so they can meet their end goals.
Well, we've had mixed results with pilots, not necessarily the outcomes, but the execution. And what we try to understand is where the partner is. If it's an economic consideration, it's drawing down a more narrow scope. You know, that's one thing. If it's organizational challenges and they've got lots of things going on, and if we don't think that that partner can engage at the level of really adopting, because at the end of the day, we are very passionate. This is a practice change. And so when you think about a pilot, all levels of the organization, in our opinion, have to be aligned. Not just the CEO and the clinical director, but the clinicians. And so when we've had those situations where it's been an economic constraint, that we deal with that separately. We then set up a pilot and we ensure that we have the best opportunity to succeed, because we're very sensitive that if this doesn't work, obviously it's a lost opportunity for us. But I think for the clinicians, you know, the technology didn't work. So any other technology solutions that are going to be advanced. When we hear that there's other organizational priorities, we generally stay away and say, come back in 3 months. Because and not that I think any of these tools need a tremendous amount of effort, but I think, again, to make these tools, to create the opportunity for the highest level of success, the clinician adoption has to be there. So there has to be some organizational focus and energy. And to your point, there needs to be a champion that really can drive the activities.
Sure. Danny?
The issue, I think, is well taken. I think you said it well, Scott, that these are all really change management initiatives, as is implementation of an EHR is really nothing but a change management initiative. It just happens to have a lot of technology around it. In general, when we look at disruptive technologies, as much as they've happened in our industry, my experience has been that clients and patients are much more ready to try them and adapt them than our clinicians. And so I think we tend to get this clinician resistance within organizations, sometimes well-founded, sometimes out of inertia. And first of all, I just wasn't sure if you would agree with that. If so, it seems like we've got what generally, not specifically, I think, Scott, you just talked about some of the organizational commitments that have to happen through the organization, but could you speak to that issue of clinician resistance generally, what you're perceiving it's from, why it happens, as one question. And then secondly, I want to riff off a little bit off what Scott said about this conversation we had a couple of years ago about how do we take that further upstream to the next generation of clinicians who are now in academic centers who are, if you think organizations are resistant to change, trying to get this stuff implemented into an academic graduate training program, my experience has been that's even harder. So how do we do that? So how do we change clinician behavior? What's the resistance at an organizational level? And then how do we move it upstream for in the academic centers?
Yeah, I mean, I would just jump in and I say for us, you know, the obvious point of resistance is if it doesn't tie into their workflow, if it's something that's adding to what they're already doing, it becomes burdensome, you know, a major burden to them. They don't want to do it. It's not something that they you know, have the ability or even want to add into their day, which, often very busy. How do you mix virtual with your inpatient? If it doesn't fit nicely into your workflow, it's not going to be something that's going to be easy to take on. Also, if you can't, very easily set up and deploy it, if it requires a lot of hand-holding, again, that first experience, really goes a long way. You want that experience to be successful, not only for the patient, but for the provider. I think I was going to add something else there, but I would say that's really important for us.
And I would say, Denny, just to put in context, we've trained 5,000 clinicians. The response has been positive. I mean, and on multiple levels, ranging from intellectual to operational. But there is a subset. And what is that? It's maybe 10%. And within that subset of clinicians, there's a range of considerations from, I'm just not literate myself in technology. We've done focus group with clinicians. God love this one clinician. She came in and said, I stopped referring myStrength because the consumer was using it too much, and they were asking me questions, and I was getting all flustered because I don't use a computer. And that's wonderful learning for us all, I think, as we think about this. And I think the bigger piece is just, okay, how do I fit this in? I've got 3 things that my clinical director says I have to do and so where does this fit in? And so within that, again, much small percentage of clinicians, I think the opportunity for us is, how do we make it really simple and integrate it with case planning tools that we can do? And Denny, I think you play an incredibly important role. I mean, it has to become, our belief is, myStrength is part of an ecosystem that hangs off an EHR, that ultimately is part of the overall clinical backbone that's being provided by the electronic health record. So I think strategically, as we all develop individual solutions, I think there has to be a convergence back to the EHR, and as we know, we're having those conversations. So that's kind of how I would kind of frame the situation for us.
I liked your focus on the consumer. When I implemented one of the first electronic health record programs in the country, we went mainstream media with our information about adverse drug effects and about mistakes that happen on the trip to the pharmacy. And we had big headlines in New York Times and CNN talking about this as the Institute of Medicine came out with their medication error report. To get an empowered consumer population to understand how they could push for this change to happen. So that's the first point. The second one is that when you look at the consumerism of wellness and fitness and managing your health to actually patient care, those lines are starting to become blurred. I've attended CES, the Consumer Electronics Show, every year for I don't know how long. The Digital Health Pavilion at this Consumer Electronics Show was the fastest growing pavilion because of tools and solutions that are empowering the patient to start asking for them, to talk to their physicians about these solutions. So I was a journalist. I know the importance of headlines. I would encourage all of us to figure out how can we get this word out that there is new innovation, there are changes, and you can start asking for them because I think that makes a big difference.
Thank you all so much. In the interest of time, we're going to have to end. I just want to thank the panelists so much for their time and for their thoughts here that they shared with us.